All right. Welcome, everyone. Thank you so much. Good afternoon, good morning, good evening from wherever you're joining us from. It's a pleasure to have you all here today, joining us today's very important section. Let me first of all introduce myself. My name is Chiamaka Obina, Project Manager and SIC. It's a pleasure to have us here today on today's section. We're looking at the topic antimicrobial resistance, IPC strategies to prevent AMR in healthcare facilities. You can agree with me that it's a very, very important topic because AMR is often called a silent pandemic. It doesn't make headlines every day, but it quietly threatens the foundation of modern medicine. So, like, just imagine a world where common infections can no longer respond to treatment, where simple surgeries or childbirth becomes high risk, especially where antibiotics no longer work. And that's the reality that we're fast approaching if we don't act fast. And that's why we're looking at this topic today. And joining us, it's no other person than our amiable Dr. Nkolika Uwezoke. I'll go ahead to introduce her. She's a chief consultant medical microbiologist and infection prevention practitioner at the Federal Medical Center, Abuja, and also a senior lecturer in the Department of Medical Microbiology and Parasitology at Baze University, Abuja. She also serves as the head of Department of Medical Microbiology and coordinator of the Diagnostic and Research Molecular Laboratory at FMC, Abuja. With over 9 years of horizontal level experience, Dr. Uwezoke has led numerous initiatives in antimicrobial stewardship, infection prevention and control, and laboratory quality management. She currently chairs the Infection Prevention and Control Committee at FMC Abuja and the FCT-NMA Committee on IPC. Dr. Uwezoke is a fellow of the West African College of Physicians, Laboratory Medicine, and holds a diploma in IPC from the University of Lagos. She has participated in several national and international collaborative research projects, including Panorama, BNAT, and eWASH, with publications in high-impact journals such as the Lancet Infectious Disease and Nature Microbiology. She's a dedicated clinician, researcher, and educator. Dr. Uwezoke continues to champion best practices in antimicrobial resistance control, stewardship, and infection prevention across Nigeria's healthcare system. Such a very, very robust introduction. And that's to tell you that, we have somebody who can handle this topic very well. Please, let's do well to welcome Dr. Nkolika with our best emoji in the chat. Dr. Nkolika, thank you so much for joining us today. We really appreciate the time that you spent to, share your words of knowledge and expertise with us. You can go ahead with your presentation, ma. Thank you so much.
Thank you so much, Chiamaka. Thank you so much for that wonderful introduction. Please, can everybody hear me? Can you hear me?
Yes.
Yes.
Okay. So good afternoon, everyone.
Yes, ma'am. We can hear you.
All right. Good afternoon, everybody.
Good afternoon.
Good morning, good evening, depending on where you are. It's a pleasure to be here today. And today we are going to be, talking about something so important that, has become a global threat, and that is antimicrobial resistance. But we are going to concentrate more on the IPC strategies to preventing antimicrobial resistance in healthcare facilities. So I'm going to use this outline, introduction, role of healthcare workers in the transmission and spread of multi-drug resistant organisms, role of infection prevention and control, and antimicrobial stewardship, IPC strategies to combat AMR in healthcare facilities, and then additional IPC strategies for specific multi-drug resistant organisms. And then I'll conclude, and then my references. So before I continue, I want to quickly go to some definition of some terms related to antimicrobial resistance.
You miss me and you saw me from coming.
So antibiotic resistant bacteria, this is defined as bacterial isolates that became resistant to the administered drug from it's not sorry, I'm not seeing my okay, so we're going to define antibiotic resistant bacteria, multi-drug resistant organisms, extensively drug resistant organisms, pan-drug resistant organisms, and then healthcare facility. So multi-drug resistant organisms are microorganisms that are resistant to at least one antibiotic in one or more classes of antimicrobial agents. An example is your MRSA or methicillin-resistant staph aureus. Then we have the extensively drug-resistant organisms, which are resistant to multiple antimicrobial agents. You can imagine when an organism is resistant to multiple classes of antimicrobial agents that have been approved for use. Example is your XDR Mycobacterium tuberculosis. Then we have the pan-drug resistant organisms. These are organisms that are resistant to all antimicrobial agents. And then a healthcare facility refers to all acute care hospitals and post-acute care hospitals caring for patients or residents who may remain overnight and require medical care, skilled nursing care, or rehabilitation services. So what is antimicrobial resistance? Antimicrobial resistance is also known as drug resistance, and it has become a global issue threatening health systems worldwide. So it is not just something affecting us in Nigeria, it has become a global issue and global threat. And it occurs when microorganisms, including bacteria, viruses, fungi, and even parasites, such as our malaria parasites that is endemic with us here, when they evolve to resist drugs designed to kill them, making infections difficult or even impossible to treat. In other words, what this means is that these microbes or microorganisms no longer respond to antimicrobials that previously they were responding to. And what this means is that the patient will stay longer in hospital, increase cost of treatment because you are not going to use more expensive drugs, and then, of course, increase morbidity and mortality. And it also encourages the transmission of spread of disease, which is where IPC comes in to limit this transmission and spread. Now, antimicrobial resistance is a multi-sectorial problem. It affects human health, animal health, and the environment. Hence, the One Health approach being used to combat AMR globally. These days, we talk about the One Health approach because we have seen there's a connection between human, animal health, and the environment. The misuse and inappropriate and overuse of antimicrobials in humans and animals and plants are the main drivers of this resistance that we're talking about today. This misuse of antibiotics in human and animal health and agriculture contributes to the spread of resistant genes, creating, just as Chiamaka said earlier, a silent pandemic threatening the existence of man. This antimicrobial resistance has become a silent pandemic. It is one of the biggest threats to global health, food security, development today. Imagine a world where people fall sick and the available antimicrobials cannot take care of that infections. That is where we are heading to. Now, One Health is a collaborative.
Dr.
Yes?
Nkoli, Can you
Yes,
put it on slideshow, on presentation mode?
it's better now.
Yes, yes, thank you.
Okay. Sorry about that. So the discovery of antibiotics in the middle of the 20th century revolutionized medical care. Antibiotics currently the mainstay of treatment for bacterial infections worldwide. However, due to the increased use of these, not just in humans but also in animals, these pathogens causing bacterial infections, which we refer to as multi-drug resistant organisms, evolved, leading to difficult to treat infections. So this use of drugs in both humans and animals is what is driving this antimicrobial resistance. Only through appropriate dosing, utilization, and careful monitoring for the emergence of antimicrobial resistance can these current antimicrobials be able to continue to treat infections due to these multi-drug resistant organisms. Now, aside parasites, viruses, and mycobacteria, the most clinically important multi-drug resistant organisms we encounter within the healthcare settings are mainly bacteria, and this includes the methicillin-resistant Staph aureus known as MRSA or MASA, the multi-resistant species of coagulase-negative staph or cons, vancomycin-resistant enterococci. You can imagine now we are having enterococci isolates that are resistant to vancomycin, extended spectrum beta-lactamase producing bacteria called ESBL, penicillin-resistant strep pneumonia, multi-drug resistant gram-negative bacilli, including the carbapenem-resistant enterobacterials, Pseudomonas species, and Acinetobacter species. And more recently, we have Candida auris. This Candida auris is a novel species of Candida which behaves like bacteria, which means it can be spread from patient to patient, unlike other Candida species. And so this is a cause of concern. Now, these multi-drug resistant organisms are transmitted mainly through contact. This contact could be directly by coming in contact with patient secretions or indirectly through fomites or equipment these patients may have used. They could also be transmitted through airborne routes. And bacteria such as your Clostridioides difficile is spread through spores, and these spores are found in feces and they can become airborne. So controlling and preventing these infections will therefore require an approach that is all encompassing. And that is where this One Health approach comes in. Now, let's talk a bit briefly about antibiotic resistance. Antibiotic resistance could be intrinsic or innate or natural. It could be acquired. When we say intrinsic, it depends on the natural or structural properties of the bacteria based on their mechanism of action. And that means that this bacteria was made that with that structural property, making it resistant to a particular drug or group of drug. And a good example is gram-negative bacteria. They are resistant to vancomycin. So there's no point putting a vancomycin strip when you want to test for gram-negative bacteria. Then we have the acquired, which occurs through plasmid transfer. And in this case, we are talking about plasmid-mediated resistance or chromosomal mutation. And this occurs as a result of changes in the genetic characteristics of the bacteria. Now, the plasmid-mediated resistance is of greater clinical importance since bacteria that have undergone chromosomal mutation are impaired metabolically and they are unable to multiply. So there's no fear of them spreading or being transmitted within the healthcare setting. So plasmids are extra chromosomal bacterial DNA elements. They are capable of self-replicating and they carry genetic information. And plasmid-mediated resistance is usually based on the synthesis of proteins which act as enzymes or they change the cell wall. This plasmid can be transmitted from one bacterial cell to another through any of these three means conjugation, transduction, or transformation. So these plasmids are one of the major ways that antimicrobial resistance comes about. The main mechanisms of antibiotic resistance are either through enzymatic inactivation of the antibiotic by the bacteria. So the bacteria can elaborate or produce powerful enzymes like lactamases, bapinamases that will just inactivate the antibiotic, and that antibiotic will not work. It could also be a modification of the antibiotic target. So if the antibiotic target gets modified, that antibiotic will not be able to, gain entry. And then we have prevention of drug entry or limited drug uptake. In this case, the bacteria prevents the drug from entering and lysis of the cell. So increase efflux, in which case, even though the antimicrobial has entered the bacterial cell mechanisms, or what we call efflux pumps, that pump the drug out of the cell, making that antibiotic not to work. We can also have genetic changes through mutation or horizontal gene transfer. So these are the main mechanisms of antibiotic resistance. So this is just a pictorial diagram showing what I've just explained, the mechanisms of antimicrobial resistance, inactivation. The antibiotic will be inactivated. They could be pumped out, increasing active efflux of the drugs. There could be modified drug target, and so that drug will not be able to bind. And then impermeability, modified cell wall protein. So these are all array of mechanisms that these organisms come up with just to resist being lysed. So let's look at the role of healthcare workers in the transmission and spread of multi-drug resistant organisms, because we know that as healthcare workers, we play an important role in the transmission and spread of these multi-drug resistant organisms. And so it is a well-known fact that healthcare workers play a vital role in the transmission and spread of multi-drug resistant organisms within the hospital environment and even in other areas. Several studies, so many studies, there are several studies that have shown this to be true. Now, this transmission and spread of these multi-drug resistant organisms results in patients coming down with healthcare-associated infections, and the hands of healthcare workers have been implicated. They have been found to be the major vehicles of transmission, acquisition, and spread of multi-drug resistant organisms. And this is something very serious, because these bacteria, they can't fly, they do not walk, neither do they crawl. So how do they get transmitted from one person to another? It could be from healthcare worker or from patient to another patient. So it is the hands of healthcare workers that have been found to be the major vehicles of transmission and acquisition and spread of these MDROs. And this means that special attention has to be paid to hand hygiene. So IPC and antimicrobial stewardship also play an important role in antimicrobial resistance. As resistant organisms continue to emerge and evolve and antimicrobials become less effective, there is an urgent need to curtail of these organisms, very urgent need. And this is especially true within the healthcare environment, which is teeming with these multi-drug resistant organisms. Surfaces within the healthcare environment, equipment, the hospital and patient care zone are usually contaminated with these MDROs. Even articles of clothing, such as our ward coats, our scrubs that we wear, and other personal items, including our cellular phones, our stethoscopes, have all been seen to harbor this multi-drug resistant organism, sometimes referred to as the super box. So you can imagine we are going with our personal items, not knowing that they are serving as vehicles or carriers of antimicrobial resistance. There are various strategies to control antimicrobial resistance, various strategies. However, the two main strategies are by decreasing the selection pressure of antimicrobials so as to prevent the selection of resistance through antimicrobial stewardship. And so this is where AMS comes in, antimicrobial stewardship. This is another big and major topic. The second is by reducing the transmission and spread of resistant organisms and their genetic determinants of resistance through infection prevention and control practices. In other words, you want to break the chain of transmission of these organisms so that they don't get spread. They get limited to that patient that has it. And this is where IPC practices come in. Now, the US CDC recommends 4 core actions to fight antimicrobial resistance. And these 4 core actions are: number 1, to prevent infections. So you can see IPC is coming up again here. Antimicrobial stewardship, which we said earlier in the last slide, to improve antibiotic and antifungal usage, because we know that inappropriate use of antibiotics or antimicrobials or overuse can also result in antimicrobial resistance. So strengthening national surveillance, One Health, via tracking and surveillance, development and use of new drugs, and the use of rapid innovative diagnostic tests that will rapidly identify and characterize resistant bacteria. We are looking forward to a day that we will have rapid tests that, within an hour, 30 minutes to 1 hour, you know that, oh, this patient is having so and so organism, and this is the mechanism of resistance it has is Staph aureus, is MRA, is MRSA. So development and use of new drugs and rapid innovative diagnostic threats. Now, role of infection prevention and control and antimicrobial stewardship still. The control of infections is one of the 4 core actions that have been identified to fight AMR by the US CDC. This is accepted globally too. AMS and IPC, they are the 2 major strategies to combat antimicrobial resistance. And it does this by putting practices and interventions that prevent the spread of these multi-drug resistant organisms within the healthcare setting. This is what IPC does. It promotes practices and interventions that will break the chain of infection, limiting the spread of these multi-drug organisms. For the vast majority of multi-drug organisms spread through contact, which I said earlier could be direct or indirect, is the major route of transmission. So contacts is the major route of transmission. And the hands of healthcare workers have been found to be the single most important vehicle for the transmission of microorganisms, including MDROs. In IPC, we usually say that if you know the mode of transmission of any particular infectious disease, then you're already almost there to knowing how to control it, because the mode of transmission will determine the IPC practices that you put in place. If it's contact, you know that in addition to your standard precautions, which are the minimum, basic minimum required of us as healthcare workers, that we need to add additional precautions, in this case, contact precautions for MDROs. So infection prevention and control is a set of evidence-based practices. I love this evidence-based practices. It's not something somebody just woke up one day to say. It's a set of evidence-based practices designed to stop the spread of infections in healthcare setting and, in fact, the wider community. So these are evidence-based practices. Effective IPC practices reduce the risk of transmission of infection between patients, healthcare workers, and others within the healthcare environment. And there are several key IPC strategies that could be used to prevent the spread of multi-drug resistant organisms in healthcare facilities, which cause antimicrobial resistance. And as I said earlier, these strategies are based on the mode of transmission of the microorganisms. And for all intents and purposes of what we're handling to multi-drug resistant organisms causing AMR is mainly through contact. So what are these key IPC strategies to prevent AMR in healthcare facilities? These key strategies include, number one, identification of patients by active surveillance. So that means that we are actively, conducting surveillance to fish out patients who are harboring this multi-drug resistant organism. And it will mean that there will be active screening at the time of admission, which we normally don't do in most of our hospitals here. Ideally, when patients come, especially when they come from other hospitals, we should screen at the time of admission, even during admission, and then when they are discharged. This is just to identify these patients who have become colonized or even infected. Okay, so if we're carrying out this active surveillance, we are able to quickly identify these patients and deal with them, and know what to do, put in place the necessary IPC practices. Now, this active surveillance also goes to the level of the clinical microbiology lab. So at the level of the clinical microbiology laboratory, it's important to also have active surveillance ongoing, because this will help to identify outbreaks. In fact, most times the lab is the first port of call where we recognize there's an outbreak. Suddenly you're seeing, maybe from the SCBU, you're seeing a blood culture results, all of them are going Acinetobacter baumannii, and that raises a red flag for us in the lab that something is going on there. So this active surveillance is very important. It helps to identify outbreaks or clusters, where you have clusters. Maybe there are some particular ones where you have clusters of these multi-drug resistant organisms. And of course, this will assist the IPC team to investigate and take appropriate IPC measures to minimize the spread and curtail the outbreak. So normally when we have this outbreak or clusters, we notice this thing, the IPC team will normally, move in to determine the cause of this outbreak, where is this outbreak coming from, and then be able to put in place interventions to curtail the spread of the outbreak. Two is the prompt isolation of patients and implementation of standard and additional precautions. So the early identification and prompt isolation is a very crucial step in the control of multi-drug resistant organisms, especially for patients who are being admitted in high-risk units within the hospital. When I talk about the high-risk units, I'm talking about places like the ICU, the CBU, the burns unit, dialysis, and the transplant unit. These are high-risk areas. So once you confirm, you've been able to identify patients admitted having a particular multi-drug resistant organisms, on confirmation, contact precautions must be commenced immediately as an addition to standard precautions, which should be part and parcel of what we do every day as healthcare workers. So contact precautions start. Use of PPE, hand gloves, use of signages showing that this patient is on contact precautions, hand hygiene, performing hand hygiene. So hand hygiene is crucial to preventing cross-infection and must be enforced. So the hands must be washed before and after removing gloves, and before and after donning and doffing of your PPE. Now, for MRSA patients, decolonization therapy should be used to reduce the bioburden of these microorganisms in these patients. So prompt isolation is key. because you don't want this patient to be amongst other patients that don't have this particular multi-drug resistant organism, because being there, they become a source. So source control is what we are doing. We want to isolate these patients and start implementing the necessary precautions, both standard and compact precautions. Hand hygiene. Every day we talk about hand hygiene, we hear hand hygiene. Yes, people will say, we know hand hygiene, but this hand hygiene is a simple action that saves life. Remember, every year on the 5th of May, we celebrate the World Hand Hygiene Day. So you can imagine how important hand hygiene is, that WHO set aside a day every year on the 5th of May for us to mark this World Hand Hygiene Day. We've said before, the role the hands of healthcare workers play. So the importance of hand hygiene can never be overemphasized. Studies abound that have shown that improvements in hand hygiene are associated with lower HAI rates, that's healthcare-associated infection rates, and or reduction in the transmission and acquisition of MDROs. So you can imagine how important hand hygiene is. Now, another strategy to prevent AMR in healthcare facilities is the presence of a functional clinical microbiology lab. You agree with me that if a facility does not have a functional clinical microbiology lab, then there's problem. There's problem. That means they won't even be able to identify properly their isolates, not to talk of knowing the resistant mechanisms, to know, oh, this is MRSA, this is carbapenem-resistant enterobacterial, this is VRE, you know. So the lab should be fully functional. And this lab must use internationally acclaimed methods and interpretative criteria. There are so many interpretative criteria. Here in Nigeria, we are using the CLSI. There's also the UCAS. There's the British one. So that lab must use internationally accepted methods, not their own methods, internationally accepted methods and interpretative criteria for the prompt and accurate identification and antibiotic susceptibility of microorganisms. They should also be up to date in detecting resistant mechanisms in multi-drug resistant organisms. This is very crucial. If not, you will now know which is MRSA, which is this. They should introduce restricted reporting based on local guidelines drawn from the local antibiotic resistant pattern. Usually, the microbiology lab is required to develop an antibiogram showing the common bacterial isolates with the antimicrobials or antibiotics, in this case, that work for them. They should also be able to establish local lab surveillance system, which they can feed into the national surveillance system, like the NCDC AMR surveillance system. Then they should conduct lab surveillance of MDROs to help the IPC team monitor epidemiological trends, measure the effectiveness of IPC interventions. This is very crucial, because if there's an outbreak and you identify the source of the outbreak and you carry out interventions, you need to go back and repeat and take swabs, environmental and all that, to be sure that your interventions worked. So also develop antibiotic guidelines based on local antibiotic resistant patterns. So you can see that having this functional clinical microbiology lab is key to prevent AMR, because if they are not there, we're not even talking about the MDROs, because we don't even know if they're there. We are not able to identify them. Next is cleaning and decontamination of patient care equipment, items, and diagnostic surgical equipment. So usually we prefer use of single-use items. They should be considered. But where that is not available, we know we're in low-income countries. So some of these things may not be available. So dedication of certain patient care equipment like the thermometer, tourniquet, and stethoscope to single patient use, we could do that. So that means you dedicate certain patient care equipment to a single patient. You don't use it for any other patients. Items that are heavily soiled or that cannot be properly decontaminated or sterilized as per local protocols should be discarded. If not, these heavily soiled items become a source of what? They become a reservoir. They become a reservoir of transmission. Now, all equipment used in surgical and diagnostic procedures like your laparoscopes, they should be cleaned, decontaminated, and sterilized appropriately. There have been studies that have shown how people picked up resistant bacteria and even infections from improperly decontaminated laparoscopes and equipment. Environmental cleaning and decontamination, this is one of the major IPC strategies we use to prevent antimicrobial resistance in healthcare facilities. Remember, the zone around the patient is normally filled with that patient's flora. And you also have the healthcare zone outside the patient zone. Both zones are teeming with bacteria. And so appropriate cleaning materials and equipment such as disinfectants and detergents should be used during cleaning. The key word there is appropriate cleaning materials and equipment. And then cleaning schedules should be increased to reduce the bio burden of microorganisms. That's to the load of microorganisms within the hospital environment. So when you're having patients who are having or who are colonized or with multi-drug resistant organisms, they are constantly shedding these organisms. So the cleaning schedules need to be increased to be able to reduce the bio burden. Special emphasis is placed on frequently touched surfaces like the bedroom, the drip stands, the windowsill, the bedside lockers, because those places we expect that the bio burden of microorganisms will be much. So special attention placed those areas during cleaning. Terminal cleaning must be done when patient leaves his or her room with other areas in contact or other areas in contact with the patient. This terminal cleaning is key because that patient leaving would have left his own flora there. That flora will constitute a source of infection for the next patient if adequate cleaning is not done. So this terminal cleaning is a must. Disinfectants should be properly diluted to appropriate concentrations, and they should be freshly prepared. Don't prepare your hypochlorite solution and use it over days. Each time you want to use, you prepare fresh hypochlorite solution, and you make sure that you are using the appropriate concentrations. This is very key. Now, education, training, and retraining of healthcare personnel. This is so crucial. They say knowledge is power. If you're knowledgeable, you have power. So in appropriate IPC practices and procedures such as aseptic techniques, how they are done, and hygiene, antibiotic prescribing. So this education and training and retraining of healthcare personnel is very key, and it's something that should be done from time to time so that healthcare workers, remember that these are the things expected of them. This is also where we have the use of posters, workplace reminders too, to help these healthcare workers remember this IPC practice that they have been taught. Now, the next is use of care bundles. This is another IPC strategy used to prevent antimicrobial resistance in healthcare facilities. So use of care bundles as a standard of care. This should be a standard of care when caring for patients, especially patients that have hospital-acquired infections such as your CAUT, which is catheter-associated UTI, your VAP or ventilator-associated pneumonia, CLABSI, central line-associated bloodstream infection, and surgical site infections. So these care bundles should be used as standard of care. And these care bundles have been defined as a group of evidence-based interventions that when implemented together, they result in better outcomes than when implemented individually. So that's what we mean by care bundles. So another strategy is diagnostic stewardship. This is another big topic on its own, and it has to do with using appropriate and timely use of the right diagnostic test for the right patient at the right time, using evidence-based practices to make clinical decisions to combat issues like misdiagnosis, incorrect treatment, antimicrobial resistance, and of course, to improve patient or outcomes. You agree with me that if a patient has MRSA and we don't diagnose it, you know what that means? That patient will be left in the open ward, and that MRSA will spread and it will become an outbreak. So diagnostic stewardship is key because it promotes and ensures best testing practices to improve diagnostic accuracy and optimize patient treatment. Then we have patient placement, which has to do with isolating and nursing patients, preferably in single rooms. But where this is not possible, like in most of our hospitals, we can cohort them. We can keep patients that have the same diagnosis together in special designated wards. And that is what we mean by cohorting patients. Now, another IPC strategy is the existence of a functional IPC committee and IPC team. You agree with me that if a hospital does not have a functional IPC committee and a functional IPC team, then there is a problem because they are the ones who are supposed to be supervising and doing all these things that we are saying. And this committee should be made up of professionals from various backgrounds and specialties who are knowledgeable in IPC. The IPC team ideally should have at least one full-time dedicated IPC nurse at the barest minimum for effective IPC supervision and monitoring. So this IPC, having an IPC committee is very key. Without it, preventing AMR becomes a big problem in that healthcare facility. So there are some additional precautions that I just said to bring out, like for gram-negative bacteria. Most of these multi-drug resistant gram-negative bacteria, they thrive in moist environment. So one of the ways we can discourage them is by ensuring a clean and dry environment, making sure bedpan washer disinfectors where available. Abroad they have these disinfectors that wash bedpans. And they also have these machines called macerators in this room that help to compress or waste. They turn it into liquid for easy disposal. So bedpans and urinals should be disinfected using heat treatment where possible, or where you have disposable versions, you can use those. I discovered that in client side, they are using a lot of things that are disposable. So many things now are disposable. They are using all because of cutting down. They want to prevent infection. Shared or communal equipment, especially if wet, must be stored dry. Where the patients have to share equipment like your suction, in between patient use, they have to be cleaned and decontaminated. We have found that several in my hospital, that those suction bottles are a breeding place for multi-drug resistant bacteria, especially Pseudomonas and Acinetobacter. Now, soaking of instruments in disinfectant solutions must be avoided. We do that a lot in our facilities. Please, let's not continue to do this, because some of these disinfectant solutions, organisms like your Pseudomonas are happy to grow very well there. Urine drainage bags must be emptied by the tap using single-use disposable gloves. You empty it by the tap, you use a single-use glove, and you discard. You don't go to use it for the next patient. A jug or container will be used for each patient in between when you want to change the urine drainage bags. All these are just to mitigate or reduce the spread of infection. Now, additional precautions for MRSA: reduce use of indwelling devices. Before you put these indwelling devices, you must justify it's needed. So its use must be justified and appropriate. And of course, they should be inserted aseptically. And then using the care bundles, you take care of those indwelling devices. Source control, just like we said earlier, by confining colonized or infected MRSA patients who have been identified, and then detecting other patients to whom infection may have been transmitted. So if you detect an MRSA patient, you have to go ahead and screen the patients in that same room or ward for that patient, just like what you do for outbreak screening, to be sure that this patient has not passed this MRSA to his or her neighbors. And then there should be an alert system in place for patients with these multi-drug resistant organisms, okay, like your MRSA, as carriage of this MRSA or CRE may be prolonged. So there needs to be an alert system. Whenever that patient comes to the hospital, that system tells the hospital that, oh, this patient, has MRSA or was discharged with MRSA. So they need to take additional precautions. Treatments of patients with MRSA prior to surgery. So if a patient has MRSA and to undergo surgery, please, we need to treat that patient to reduce the spread of MRSA during surgery. Now, patients who are colonized undergoing surgery should receive decolonization therapy prior to surgery, starting from 5 days before that surgery. Patients, where possible, they should be the last patient on the list where possible. Where not feasible, like in cases of emergency surgery, the theater surfaces in contact with the patient should be thoroughly cleaned and decontaminated before being used for the next patient. The reasons are clear why we need to do that. All infected or colonized lesions must be covered with an impermeable dressing during surgery, because we don't want secretions leaking out from these colonized wounds, touching everywhere in the theater. Patients should be allowed to recover in a separate suite, not occupied by other patients. Bed linen, undergarments, nightwear, where feasible, they should be changed daily. And disposable washcloths should be used in hospitals. Where not available, the washcloths should be washed every single day. Now, we talked about Candida auris, which behaves like a bacteria. And this is a newly discovered Candida species, which behaves like bacteria, which means it can be spread from one patient to the other. So once an index case is identified, the managing physician should be notified, and the patient should be decolonized daily with a topical solution of 2% chlorhexidine gluconate bath, with daily changing of bed linen. Screening of the groin and axilla of all patients in the same vicinity or room with the index case should be done, because this Candida auris has the propensity to spread very fast. You should also carry out an environmental surveillance by swabbing and screening high-touch areas and shared equipment in case this Candida auris has spread to this equipment. And screening of patient relatives who have been in close contact for between 48 to 78 hours is also very important. Screening of patients that use the same medical devices with same patients should be done by collecting one swab from both axilla, and then one from the inguinal region, one from the rectum, and if that patient is catheterized, we also take a urine sample. So you need to screen patients that use the same medical devices with this index case that you discovered. If medical device or instrument is to be jointly shared, it should be cleaned thoroughly and disinfected after use, and you should ensure correct exposure time when you're doing this, so that you ensure that every trace of this Candida auris, is gone. If possible, there should be a dedicated staff assigned to care and clean this patient's room. That way, other staff and other patients will be spared, the transmission of this multi-drug resistant strain of Candida. This Candida auris is very difficult to treat. It's multi-drug resistant. So another thing to do is to educate all healthcare workers about Candida auris and the risk associated with it. So this is a summary of IPC measures for multi-drug resistant organisms, patient placement, hand hygiene, our big hand hygiene, use of PPE, various PPEs, contamination of items, equipment, proper waste disposal, which means we need to segregate our waste properly for effective waste disposal using our color coding system. And then laundry is also very key, especially when you're dealing with patients who have MRSA or Clostridium difficile, because this can become airborne when you're handling your laundry. So no shaking or agitating of laundry in the ward. They should be handled gently and processed as infected according to the local hospital policies. So laundry management is also a key IPC practice that helps to mitigate the transmission of MDROs. So in conclusion, infection prevention and control plays an important role in the control of AMR by providing us with practices which are evidence-based and interventions too that seek to break the chain of transmission of microorganisms, thereby limiting and in some cases preventing their spread. As new agents emerge and are being used in the care of patients, pathogenic bacteria will continue to evolve in response to this selective pressure. This is AMS comes in to reduce the selective pressure. And with the paucity of new antimicrobials, we all know that there's paucity of new antimicrobials in the pipeline. It is pertinent that infection prevention and control practices must be promoted and performed, especially in the healthcare setting by healthcare. Alcohol-based hand drops have been found to be effective over soap and water with regards to lodgement and removal of microorganisms. However, note for spore-forming organisms such as your C. difficile, hand washing is preferred. And of course, when your hands are visibly soiled, you have no business using your alcohol-based hand drops. Hand washing is done first before the use of your sanitizers. Remember, hands saves lives. Conclusion, IPC is everybody's business. Be knowledgeable, be well informed. Prevention is better than cure. Thank you so much. Thank you for listening.
Thank you so much. Thank you so much. Please let's appreciate our speaker.
Thank you, ma'am. Really appreciate it.
With our best emojis in the chat. Thank you so much, Dr. Nkolika, for that insightful. Oh, please let's mute our mic. Thank you, Dr. Nkolika, for that insightful and eye-opening presentation. Thank you so much. You've actually clearly highlighted that combating AMR in our facilities requires consistent IPC practices and also behavioral changes at every level of our healthcare. And also your points on the role of hand hygiene compliance, a functional clinical microbiological laboratory and environmental cleaning in breaking transmission chains is very, very important. And actually this has set the stage for deeper reflection amongst we IPC practitioners. And now to complement that perspective, we'll be hearing from our next presenter. Church is here, Dr. Mrs. Grace. I'll go ahead to introduce her. We're going to take our questions later. Please do well to note them. Our speaker is still on standby to take our questions, our contributions, and also our comments. I'll go ahead to introduce our next speaker, Dr. Mrs. Grace. She'll be taking us through IPC improvements in her facility. Dr. Mrs. Grace is a consultant public health physician at Benue State University Teaching Hospital, Makurdi. She's a senior lecturer at the College of Health Sciences and Moses Asai Adazu University, Makurdi. She's a speaker at primary and secondary school seminars, youth and marriage conferences, and also a book author. She carries out free food distribution and medical outreaches to rural areas and IDP camps. She is married and also blessed with 3 lovely children. I'll go ahead to project her slide right now. Dr. Grace, you're welcome to today's section. Please go ahead while
Thank you.
Yes, I project your slide now.
Okay, thank you so much for the opportunity. Good afternoon, everyone. I want to really appreciate, thank you. I want to appreciate the first speaker for that very wonderful presentation. To present my experience.
Okay.
Yes, I can see the slide. Yes, I can see the slide.
All right, go ahead, ma.
Okay. I can see this. Okay.
It's not like a presentation mode.
Okay, go ahead, ma.
All right. So, I'm going to be talking about the improvements, the infection prevention and control improvement that has occurred in Benue State University Teaching Hospital since I received training that's commenced sometime early this year. The was organized by CSCAP, and we had the online sessions, and then we went for the practical sessions. And by the time we came back to the facility, you'll see a picture of an overview of our facility there. Next slide. So by the time I returned to the facility, I was able to clearly see what were our challenges. Before the training that I had with CSCAP, I didn't really understand what the concept of infection prevention and control was all about. Apart from what we're taught in medical school and the little things that we do here and there to protect ourselves and to protect the patient, I didn't really understand the concept. But by the time I returned from the training, I discovered that the IPC committee was a very critical aspect to maintaining IPC in our facility, Benue State Teaching Hospital. So before the training, the committee was on ground, but was not very active. So, but after the training, we ensured we started having regular monthly meetings and then weekly inspections and supervisions of the hospital environment by the IPC team. Now, our committee in Benue State University Teaching Hospital is... Hello?
Yeah, please, can we mute this person, please? This noise. Please.
Zion, please, can you mute yourself?
Zion, can you... The host, can you mute the person?
Hello? Hello?
Yes, please go ahead.
Yes, that's better. Okay, all right, thank you. So before the training, we had a committee, but it was not very...
We're unable to hear you, ma.
Yeah, all muted, ma. You can continue, ma.
Hello, can you hear me now?
Yes, please go ahead.
Okay.
Yes, ma'am.
All right.
Clear.
So the committee that we had on ground, we had the committee and then we had the IPC teams. So for our team, it's made up of 5 persons, myself, the IPC focal person. Then we have the 2 IPC focal nurses that are full-time IPC nurses in the hospital. And then we have somebody from the data that helps us to be able to do a continuous quality improvement, gather data to be able to see before and after all of our different findings. And then we have the environmental specialists also with us. So, however, we discovered that because of the work, the hospital is a 300-bed capacity hospital. We had to further come up with a strategy within the committee, and some other very active members or people within the hospital setting were brought on board. So we now have sub-teams. We have a group of 4 sub-teams, and they are assigned weekly activities, monitoring and supervision of cleaning, hand washing, the waste management, and even the food vendor inspection. So we have those sub-teams, and that has given us a lot of room to be able to carry out this activity. So the infection prevention and control team basically now works together with the sub-teams to be able to ensure that the weekly activities are carried out in the hospital. Before this training, I did not understand what all of that was all about. The next slide, I just picked one out of the areas that were improved, as a result of this training. The next shows right in our intensive care unit. The next slide, please. Okay, thank you. So the next slide now, it shows that right in our intensive care unit in the hospital.
All right, go ahead, Ma. We can't hear you, Ma. Hello, Dr. Grace, are you there? Dr. Grace, we're unable to hear you. I'm not sure you're still on the call.
It's like she's having network problem.
Okay.
Oh, she muted herself. She muted herself mistakenly. I don't know.
Yeah, sorry for the interruption. So
right.
we had that particular tap that you're seeing among the various interventions that occurred as a result of my training. We had this tap that was not functional at all. There was no tap head right in the intensive care unit in the hospital. But after the intervention, I was able to know the importance of this. So I went from one site to the other. We have a team on ground that goes to inspect the taps and their functionality. And so when we discovered this, next slide, please, we're able to bring the attention of the maintenance unit of the hospital. And next slide, please. The tap was duly fixed, and not just fixed, but the staff were trained also on the importance of washing their hands with running water. Because we discovered that, the next slide, please. We discovered that the knowledge gap was the main issue, and the attitude of staff was the main issue that we're contending with. Next slide. So that resulted in the next step that we took. The next step that I took after this training was to do a practical cleaning session with over 89 cleaners in attendance. The Benue State University Teaching Hospital has two centers, the main center and the annex. So the annex is a different building in a separate location. We're able to train more than 30 of the cleaners at that location. And then at the main center, that's the picture you're seeing there, we did a practical demonstration. We showed the cleaners the 3-bucket system. We're also able to teach them how to dilute jig, which we were practically taught during our CSCAP training. We were also able to teach them the best cleaning practices. We taught them risk assessment. We taught them how to clean from the high areas to the low areas. We taught them to clean from the clean area to the dirty area. And then we also taught them to clean the high touch areas. All of these were things that were new to them. Most of them were not aware of this. In fact, we were able to ensure, next slide please, we were able to ensure that our training had a very, very clear, measurable difference. So we had a pre and post test that was done with the cleaners. Next slide, please. So for the pre-test, you would see that 34 out of 8 cleaners, out of the 89 cleaners, had good knowledge. They were able to say, okay, cleaning practices includes cleaning from the clean area to the dirtier area. They were able to tell us that, okay, they knew that they were supposed to dispose waste in the different colors of the coded bins. So we took them on those practical questions, all right? But 34 out of 89 of them had good knowledge. However, after the training, the knowledge increased to 56 out of the 89, which is over 50% improvement in the knowledge. And we decided that our target is 100%. So right there and then, we fixed another training, which will encompass more of the cleaners, and that's to hold next month. So in that training, we hope to break down the cleaning practices to step-by-step cleaning of the different areas. In the CSCAP training that we attended, we're trained on how to clean the sink area, how to clean blood spills. So we are going to take those practical individualized sessions during our next training in November. And as you can see the statistics too, we discovered that we also asked them, 13 out of the total number acknowledged that they have had needle stick injury once, and 14 acknowledged that they had had it twice, 15 acknowledged that they had had injury thrice, and then 23 of them acknowledged that they've lost count of the number of times that they had needle stick injuries while trying to dispose of the deaths. 25 said they've never been pricked. So this was a real issue for us after the training, and we had this. The next thing that we quickly did to be able to combat this was we taught them how to manage waste disposal. Secondly, we're able to get, with the support of APIN public health initiatives, we're able to get the hepatitis B test strips. So we are now, as I speak right now, we are running free screening for hepatitis B, for HIV, for all the cleaners. So that from that, with that backup, we'll be able to vaccinate those of them that have not been infected, and then refer appropriately those that are already infected. And many of them did not know that this is the appropriate step to follow when you have been pricked with needle stick injury, but we're able to teach them that during the training. Next slide. Then we also have a very marked improvement. Before this training, there was nothing like waste segregation in the hospital. We had a green bin and a black bin. Those were the two things we had in the hospital. But right now in the teaching hospital, as you can see, we have color-coded bins with bin liners. All right, we have color-coded bins with bin liners, which also we emphasize the importance of this for the cleaners and the hospital staff. We have not just had training for hospital for cleaners, but we've also had for hospital staff, which covered the staff in the nurses, the doctors, the lab scientists, pharmacists, and even the administrative staff. So we've been able to do that too. Next slide, please. However, one of the challenges that we're still trying to combat, we hope that we'll be able to handle that, is the faulty incinerator that we currently have. Then another thing that I learned during the training that I've also implemented is the inspection of food vendors. Prior to this time, I would see food vendors and their location was close to a drainage system, what we call a gutter in the hospital. And there were no safe food handling as such. They were just doing whatever they wanted to do. But after this training, our sub team went out and were able to do a proper food vendors inspection. I speak to you right now, the food vendor located to a better place. So where they are sited now, there are various groups there, and we have also issued out questionnaire, and we've been able to see that there are some gaps. One of the gaps that we observed is the fact that the waste disposal was poor, and even the attire of the food handlers, leaving their hair exposed and all of that. So we made our recommendations. However, one of the major gaps we saw was the screening of the food handlers, and even taking samples of the food to run tests to be sure that they are safe. That is also in the pipeline. The screening process is about to begin. We've already procured we've already gotten those hepatitis B strips, HIV strips, and we also want to check them for tuberculosis. However, we have a code of confidentiality. Whoever is infected will not be stigmatized. Rather, we'll follow them up to ensure that proper management is given to them so that our food is, and themselves too, will be doing well. So that is another success that I've gained as a result of this training. So the next steps, as you can see there, because of the knowledge gap, I have not yet reached the target, which is 100%. We are going to continue. The trainings are going to be continuous and ongoing. Like the previous presenter said, we can never overtrain. Rather, we are under training, because most times one of the challenges we have is the challenge of shifts. Staff run shifts. So we're going to go name by name to ensure that everyone in the hospital has had some training on infection prevention and control before they can even get the opportunity to be retrained. So that is ongoing. And then continuous advocacy to management. We have been, from the time I finished my course, and I discovered that management is a key element to having to, penetrate and have success in infection prevention and control. So we have been able to carry management along. That is something that we have not been doing before. We have been able to present our plan. There's a work plan, and also we are trying to secure a budget for IPC activities. All right, so that is still something that is ongoing. Then continuous supervision. At the various duty posts, we have weekly activities to ensure continuous supervision and, of course, monitoring and evaluation. I did not know until I've had this training that continuous quality improvement, for you to be able to measure continuous quality improvement, you must have data analysis. You must have pre and post data. So that has been a big one for me and has helped me to be able to make targets with the whole IPC team and committee, and to come up with modalities to reach our targets. So in summary, I would like to thank, next slide please, I would like to thank CISCAP for the wonderful opportunity to have been trained. And I can assure you that all the work that you did for us was not in vain. I have been richly enlightened, and indeed, many people are getting enlightened over here in Benue State University Teaching Hospital. Since I finished my training, I have been able to step down to at least 200 persons. All the training experiences, at least some of the training experiences that I've gained. I also appreciate APIN and NCDC and the Benue State University Teaching Hospital Management. Thank you very much for listening.
Thank you so much, Ma. Thank you so much. It's very interesting to see so many improvements in your facilities, and they are actually, what's, celebrating. Very, very interesting. Thank you so much for that time. We really, really do appreciate it. And because we do not have so much time, I will go through the chat now to see some of our questions. Please, if you have a question for the speaker, especially the first speaker, please, or even to Dr. Grace too, please go ahead to, okay, let's appreciate her. Let's appreciate the second speaker. So thank you so much, Ma. Okay, so I can see a hand up so that we utilize our time. Okay, Dr. Goswill, please go ahead, sir. Go ahead to ask your question.
Yeah, thank you very much, my mega chief. It was so good listening to you. Such an awesome presentation. In fact, I've never heard it like this. Thank you so much, Ma. That was brilliant. So, on this antimicrobial, just like we had in the meeting before now, we discovered there's a lot of systemic issues to address, which is what I would like to put back to you. Start with other stakeholders, what we can do at local levels. I remember some time ago, we sent a patient for urine MCS, and the result out pan resistant. All the drug tested were resistant. And did you know that this lab is an ISO, I forgot the number, it's an ISO certified lab. And the lab itself did not do as if anything has happened. Me, I was shocked. Because in other climes, if you do a culture and you see pan resistance on a patient, everybody will be running helter-skelter. Something is going on. But it was just as if nothing happened. They just handed over the result, and it was like, go and continue your life. They didn't bother to check on the patient or to get in touch with what is going on. It was shocking. So we really need to raise this awareness among clinicians, I mean, even our lab personnel, for them to know that these issues is not just about churning out result, giving it to patients. They should also take steps, to get involved in proffering solutions to antimicrobial resistance. I just report this experience, and I said I should share with you, so that healthcare workers, we know that we have a significant role to play in combating AMR. Of course, you've listed all the drivers, and I just hope that we'll get it right in this control to push this program forward. That was just a comment. Then for my very good colleague, to Grace, your activity is very, very commendable, and I'm sure that those of us who are part of the CCAPS training will be very, very happy that you participated, putting what you learned during that training into practice. But I want to add that it has been shown and proven over time that knowledge is not usually our main problem in this part of the world. It's translating the knowledge into practice that is. So while I'm commending you for training this group of healthcare workers, I also want to add that your team should now work to encourage them to practice what they have learned. Now, there are 4 levels of assessing the impact of training. Of course, you have done the second level, level 2, which is pre and post test. Now, level 3 is what most of us don't do, and that is whether those healthcare workers are able to practice what you have taught them. Now, we'll be very that after participating in that training, you are now practicing it. So that's a kind of level 3 assessment. So at the front lines, we need our healthcare workers to practice this thing. I see the beautiful color-coded bin that have been provided. We desegregate the waste at the point of generation. Go to most facilities, we've done the assessment. You have the color-coded bins, but yet people will not segregate the waste that is generated. So the bottom line, what I want to emphasize here is that while you are doing this great job, you need to take it further to see how both yourself, your team, and your management can support frontline workers. This is where it really matters, what they do at the front lines to practice the waste management, to practice environmental cleaning, is very, very key, because if they know it and they can practice, then of course we will not achieve the aim of IPCs, of course, combating HIs, preventing the transmission of HIs in healthcare facilities, both to patients and to healthcare workers and even to visitors to the facility. So I want to encourage you, Grace, to go back and work on taking your intervention to the next level of assessing behavior change. I think I will drop here for now because of time so that others can also contribute. Thank you, and over.
All right. Thank you, Dr. Goswi, for that very important contribution. Like you said, implementation, also sustaining whatever they have been learned. Sustainability is a very important factor in that equation. Dr. Grace, while you were talking about the screening of the food vendors, and you mentioned TB amongst others, so there's a comment here to say, please remember screening for Salmonella typhi for the food handlers. Please so take note. Okay, there's another hand up here, Dr. Onyekachi. Okay, please, sir, you have the floor now. Go ahead, please.
Okay, good afternoon, everyone. I just want to thank everyone for making our time to be in this meeting. I want to thank Dr. Tonkoli for that beautiful and enriching presentation. It was quite loaded. I don't have any question. I just want to add volume to what she has said. And I just want to say that if you look critically in what she just presented, she was hovering around all I would say our standard precautions, and we can see that these things are very, very, very key, the components or things that make up the standard precautions. We can see that it's something that we cannot do without. It's very, very key. Another thing I want to say is that we can't do without these things. Let it not be like a hearsay kind of thing. I had a situation in my facility, and we had an outbreak in one of the ICUs, the pediatric ICU. And, in the course of the discussion, they mentioned that they were going to do fumigation in that space. And I was like, fumigation, it doesn't really work, And, it's something about speaking up and actually taking up that challenge and making sure that it works, And I took the bold step and telling them that this was not going to work. And I gave them the reason why, proper terminal cleaning and disinfection, cleaning and inspection is the issue. And that's the mainstay in handling this particular case. And, for everybody just left the thing for me and say, oh, okay, do your cleaning and disinfection now. After, I'll come and do environmental swapping to know whether I got it right, that kind of thing. So it was more like a challenge. And I just said to myself, we can't be teaching this and we're not doing this thing. So I took the bull by the horn, and we did thorough cleaning and disinfected the spaces, high touch services, every other spaces, and the MCV department came and did this environmental swabbing, and and we didn't see anything at the end of the day. I'm not just saying this just because I give myself kudos. I'm just saying that, I'm like just trying to liken what her presentation. I want to talk about these HAIs. I want to talk about all these antimicrobial resistant things and all that. It is real. So for me, I can't be telling the cohort, I can't be telling people, you must clean, you must this. I did it myself. It worked, that kind of thing. So I'm just trying to encourage the IPC practitioners here and all that these things, and she was very careful when she used the word evidence-based. They're really working. It's evidence-based. So whatever you've learned, whatever you know already, put them into action, and that's it. And since then, people just that kind of, the mindset, everything has changed, now changed. Everybody's in the hospital, they're like, oh, whatever he says, whatever he's, the listening ear is there, the attention is not given to the IPC space. So all I'm trying to say in essence is that, I just want to encourage somebody out there, everything you've heard, everything you've been taught, and try to put them into action. Yeah. And another thing I want to add to this is, she mentioned something, but because of time, I'm sure she didn't really put so much energy on that. It was things around care bundles. I'm just trying to challenge everyone to see how we can actually make these care bundles work in our facilities. She's already done, she did a really good work on telling us what it's actually made of. If we can say, oh, in this particular procedure or in this particular condition, we must apply care bundles. And if these care bundles are 3 to 5 combination of things to make it work, the IPC thing, it has a wrong way in, trying to prevent infection and avoiding the multi-resistant organisms here. And I know that this care bundles is embedded in all or nothing rule. So every step must be done. You can't even jump it. So I'm just trying to encourage the healthcare worker out there now to make sure we apply care bundles really in everything we do, in our catheter management, in our ventilator management, whatever we're doing, even IV in our ears. When we want to give blood and everything, whatever you think you can create out of your care bundle, let's make sure we imbibe it, so that younger or other healthcare workers can say, oh, this is the SOP, this is how we're going to do this. I think we'll make a headway in our facilities. Thank you, Dr. Nkoli, for that wonderful presentation. Then Dr. Grace, it's good to see you or hear your voice again. Thank you for that loaded presentation as well. I like everything you've said. It was nice with your hand hygiene things and all that. But I just want to say, first of all, that in that your tap, that hand hygiene setup you corrected. I think we need to complete it by making sure that the reminders are there, not just fixing the tap, just try and see how we can put up reminders around that space so that it builds that culture. And then you did a lot on cleaning. I want to commend the support you've got from EPIN. I want to commend your waste management. I want to commend everything. But like Dr. Bonaya said, you need to do, you mentioned it, the needs assessment. So by the time we are doing our training, what gave you rise? Why did you train? Why did you have to train? So there must have been a need, a gap that you wanted to fill, you get. So we need to look at it very well so that you can demonstrate these things very well. And I was just thinking that, you would have brought in, in because of this thing, the multimodal strategy in these things you're doing, you would have also made your presentation very well. And, so you train, that's fine. Then what do you do? What about your supplies? Those gaps should have been there. So if you have done your needs assessment, you would have seen that there is no this, there's no this. Yes, I know you noted that you did the pre and post education and the knowledge is gap, but what about the items? What about the things there you get? Then these are the tools that will give you, these are things that will give you room for your advocacy, which you mentioned. So by that time, you're now meeting your management, you're putting everything together, you're also trying to monitor the training by looking at what they are doing. You're also trying to monitor your waste very well to see, are they not doing it? Not just having a picture of, the segregated whatever. I have it in my facility, but we're not segregating very well. So we need to see, or at the end of the day, are they segregating well? Do you get what's the impact, like Dr. Gospel said, Then another thing I want to advise you also is, and you want to have 100% pass rate, that's beautiful. So you need to also look at your communication plan. How are you communicating this so that you know it's too much energy and resources trying to make the 100% work, So these are health domestic stuff. I'm sure your language is very understandable. I'm sure the mode of communication is very simple and clear. So if so that it's easier for you sure that people really understand. And once they know this, they will also give it to you. Thank you. Let me stop for now because of.
Okay, thank you so much, Dr. Ikachi, for that beautiful contributions.
Hello?
I'm sure. Yes, we can hear you. I say thank you.
Thanks, sir.
Yes, I'm sure
All
it's
noted,
duly
sir.
noted.
Thank you so much.
All right, thank you so much. I saw a hand, but I'm not sure if he's still here. Dr. Salisu, are you there? Okay. Yes, the slides will be shared.
I think I'm here, but
Okay.
Dr. Onyekachi has really made, he has mentioned a lot on what he has already said it almost all what I have. But by and large, the presentations are actually apt, especially the improvement part of the Benue State Teaching Hospital is quite a step on some that actually, if she continues such a thing, is going to make her feel she has been doing a good thing since they are just starting. I think it's quite a commendable approach, and I wish you all the best. But one thing that I wanted to say is try to engage more on your nurses, because I understand most of the clinicians, the physicians don't have much time to do this IPC dedicated job. So give them a kind of ownership, truly ownership, so that they can do the job. You definitely appreciate it. That's just a suggestion from my own aspect. The nurses that you dedicated for the work, give them that ownership and engage them. Let them understand every bit of doing it so that they won't be disturbing you much. Definitely, you're going to see a good result from their own part. Thank you so much, everyone. Thank you, Dr. Inkolika. Thank you so much.
Okay, thank you, everyone. Thank you, Doctor. Thank you for that contribution. Okay, so it's duly noted. So I'm just browsing through the chats. We do not have so much time, but I'll just read them quickly. Okay, so she's saying that committees for IPC should not be too large so that you don't end up having people who may actually not have the enthusiastic orientation and step back, and when there's no funding for meetings or commitments. Okay, there's a question from Dr. Johnson. He said, my question is, how do you intend to handle the behavioral challenges among different groups? Okay, I think that question is for the first speaker. When people do not want to take up some of the behavioral changes that they should implement amongst themselves, how do you handle that? Dr. Colleen, are you on the call?
Okay, hello. Can you hear me?
Yes, ma'am.
Yes. Before I answer the question, I just want to, congratulate Dr. Grace for the great work she's doing. I was just, wow, I was amazed. All she has been able to achieve just within a short time. That's really amazing. Doc, well done. Well done.
Thank you, ma, for taking
May God bless your efforts. Yes, well done, well done. Well done. Yeah. So the behavioral changes aspect of IPC is like a big challenge because people, are used to doing things in a particular way. And for us, IPC is something that we are trying gradually, we are trying to come to terms with, we are trying to adjust with. It's not something we grew up with. That's why we're advocating that IPC should start from an early stage. In fact, if possible, from primary school, people should start learning about IPC, secondary, in the university, because when people are adults, it becomes difficult to change their ways. So it's quite, people just want to continue doing what they are doing. And I think that's what, translating knowledge into practice is the big gap the big challenge that we are facing. And that was why the SCDC, in their wisdom, they came up in partnership with Robert Cox Institute. They came up with the PALS method or PALS approach. The PALS stands for Participatory Approach to Learning in Systems. So, what this PALS does is helping us translate IPC into practice, because that's the problem. You know, we say we are doing trainings and people are still doing things the same way. So we ask ourselves, is there something we need to do differently? And this is what PALS is all about. My prayer is that with more trainers being trained, more people will become change agents in their various institutions and will be able to, you know, put in place what they have learned, because these things affect behavioral change. For example, you know, PALS deals with translating IPC into practice. It teaches us a whole lot of things. The iceberg model. You may have somebody working with you, she's always coming to work late, you know, and we are busy. Why are you always coming to work late? Madam, every day you're coming too late, or you're not doing this thing well. But we have not called that person to find out. Why, madam, how are you? What are you doing? Is there any reason? I noticed this. Is there any reason why you're doing this? Is there any reason why you're doing late? I tell you, you'll be shocked that that person you're shouting on, she's coming late, she's battling a sick spouse at home or a sick child or something. You know, by the time you engage that person effectively, you communicate with that person effectively, you're able to find out this problem and, you know, help the person find ways to tackle that problem. The other thing again is letting people take ownership of things. When you tell people what they do, they don't take ownership. That's what we found out. But using the participatory approach, where we want everybody to be actively engaged or to participate at the highest level, nobody is left out. That means that if you notice, for example, in a particular ward, that waste segregation is a problem, it means that that particular ward, something needs to be done. And in doing that, everybody's voice counts. In PALS, every voice counts. You see that cleaner you're thinking that might not come up with a solution. I tell you from experience, they are the ones that come up with the best solutions. So one thing the PALS approach does, it allows every voice to count. Everybody comes up with ways. Oh, we noticed this. Okay, who are the stakeholders? Who are the stakeholders in this thing we notice? We notice we're not doing hand hygiene. Who are the stakeholders? Or we notice waste disposal is a problem. Who are the who are the stakeholders? We engage these stakeholders. We have a meeting with them in a way that they are able to let us know their problems, in a way that they're able to come up with the solutions themselves. When people come up with solutions themselves, I tell you, that is taking ownership. They take ownership of that program or that particular thing because they don't want it to fail. They have come up. You didn't tell them, you have to do this, you have to do this. No, it's only an observation. Okay, how do we tackle this? The ball is on your court. My people, how do we solve this thing? And people bring suggestions, and you'll be amazed many times. It's those people that we feel that don't know anything or wouldn't know what to do. They are the ones that come up with suggestions that work. So that is a way we can tackle this behavioral thing using this participatory approach to learning in systems, where every voice counts, everybody is allowed to voice his or her own opinion, you know, and at the end of the day, people take ownership because they are actively participating in that thing. They are actively, you're not telling them what to do. They are the ones coming up with the solutions. And they are the ones that want to make sure those things that they came up with work. By the time you do that over time, you know, and you apply other models and things that you talk, like this iceberg model, you find out that those people that you're thinking they can never change, they start changing. You'll be amazed, they start changing. So it is also something that we can put into practice, you know, even the way we talk to people when we want to correct. How do we correct? Hey, madam, every time you clean, you don't clean well. What is wrong with you? No. The way we communicate, is it effective? Is it non-violent? So many times we communicate non-violently to our workers. But when you communicate with love, you correct with love, that person will make a conscious effort not to do that thing. So I agree with the person, you know, that brought up this question. This behavioral change is a big problem, and it is one of the major drawbacks or setbacks we see in translating IPC. So, but that is what the participatory approach comes to take care of, translating IPC into practice. I hope I've been able to answer your question to the best of my knowledge. Thank you.
Wow, very, very interesting. Thank you so much for that beautiful response. Very, very beautiful response using pulse. Okay, so quickly, I would like to say that our feedback form is in the chat. We'd love to know ways that you want us to improve on the program. Okay, yes, I'm seeing a comment here, engaging everyone. Okay, so you're buttressing some of the things that she has said. Engaging everyone, allowing room for ownership, get moral insights from everyone, active participation, allow room for facility-based model, proper communication, behavioral change. Thank you so much, Dr. Emmanuel James. That's beautiful one to put together there. So our feedback form is there. I want to say thank you to everyone. Please try to fill the form. The link is there. We're going to definitely get the recorded section and the slides. Everyone will get it in our emails. And congratulations to ECHO Africa. Today is 10 years. ECHO is celebrating 10 years. And that's extension of community health outcomes. Thank you to ECHO for offering their platform for this monthly section. And they're also celebrating 10 years in Africa. And that is a beautiful one. I want to say a very big thank you to everyone who took out time to join today's session, and most importantly to our speakers, Dr. Nkolika Uwezuki and also Dr. Great. So it was a very interesting section this afternoon. Thank you for taking out your time to share a beautiful from your wealth of experience and expertise. We really, really appreciate it. Thank you so, so much. And at this time, I would love to draw the curtains. We've exhausted our time, and I look forward to having everyone next month. Next month is, by the way, 2 days, tomorrow or next. We all are aware of the world celebration of our AMR week, and that's in the month of 16 to 21, yes. And we've already planning out our sections for that month, and also we're going to share invitations to everyone, and we want you to be part of it. And do well to share some of the activities that are going on in your communities. Not community, your facilities with us and secure, so that we can share on our social media platforms during the celebration next month. Yes. So to tell us that this session is very, very timely and important, and I hope that we don't just listen, but we're able to implement and ensure that it's sustained in our facilities. Thank you so much to everyone, and thank you to our speakers. Someone is saying, please, we have certificate for this program. Okay, so there's modality for that. It's not just a one-off when you participate in the training, just one-off, you get a certificate. It's actually for people who have been very consistent with the platform, yet joining the trainings, and we'll share more information about that. Thank you to everyone. And at this moment, I would love to say goodbye and see you next month by the special grace of God. All right, bye everyone.
Bye-bye.
Bye. Thank you.
Bye. Thank you.
Bye, everyone.
Bye-bye. Bye-bye.
Bye.
Share the slides with the participants.
Yes, I'll share the slide with this recorded section with everyone.
Bye.
All right. Thank you, everyone. And God